This is Dr. Ward doing a second mic check.
Got you loud and clear, Dr. Ward.
Just for technical check, Jason, I'm signed on multiple devices so that I can see my notes. So if you see two identities of me, that's correct. It's 11:03, and I noticed that we have about 141 participants at this time. As is customary, we're going to wait an additional minute, maybe two. Beautiful. Welcome, everyone. It is 11:04, and I'm seeing that we are up to 175 participants, and we continue to flow in. So I'm going to wait one additional minute to get us started to ensure that those who are joining do not miss any of the messages. Just got some feedback through the Q&A that I'm a little difficult to hear, so I'm doing another mic check, and I'm going to raise my voice a little bit. Is that better? Thank you, Bill.
That is better, Dr. Ward.
Happy to speak up. Well, it is 11:05, and we are up to 189 participants at this time. I can see that we are live and recording. I'm going to go ahead and get us started today. I'm going to try to overemphasize my articulation and my volume today. This is the first time that I am using a different set of headphones, so that may be the culprit. but please do continue to send feedback if anyone has difficulty hearing me throughout the course of the call or any of our other panelists. So good morning. Welcome. Today is July 29th, 2020, and this is our 12th in a series of calls for Medicaid behavioral health providers that seeks to provide verbal updates on our response to the COVID-19 state of emergency and associated guidance. My name is Dr. Alyssa Ward, and I am the Behavioral Health Clinical Director at the Virginia Department of Medical Assistance Services. We appreciate you being here with us today for this WebEx event, and due to the large number of participants, as usual, everyone will be muted except for our panelists. We will not be answering questions about service flexibilities or Medicaid policies during the course of the as we are trying to stay mindful and attend to our presentation. At the end, based on time, we may have a moment to answer some questions if we see them in there, but we do want to direct you to our two email boxes that we have, enhancedbh@dmas.virginia.gov, as well as sud@dmas.virginia.gov, where we always welcome your questions and answer with pretty good efficiency to those questions. That is where you are most likely to get the most comprehensive response rather than the short responses that we can provide in the Q&A box. It is always possible to listen to this call over the phone, but we do encourage participation on your computer as we do have slide content to share. I'm joined as usual today by our amazing team. Today we have Jason Lowe, our new Support Act Grant Manager, who is filling in for our Behavioral Health Manager, Laura Reed. He is hosting the event and managing our slides. He will also be presenting today. We are also joined by Ashley Harrell, our Senior Program Advisor for the Arts Program. And we're going to go ahead and get started in review of the agenda. So as usual, I will be going over the purpose of the call and some global updates and resources. I'll be followed by Jason Lowe, who will present the results of the second telehealth survey that we have conducted with you. And then Ashley Harrell will review some additional resources for providers today, as well as discuss some of the frequently asked questions that have come into our email boxes, and then I will take us out to our conclusion. We are now 4.5 months into this state of crisis related to the COVID-19 pandemic, and we remain very vigilant to the VDH data on the spread of COVID-19 and testing data. As the pandemic continues to evolve, we stand prepared to adjust any of our guidance or flexibilities to reflect appropriate mitigation measures important for protecting the health and safety of both our members and providers. We do not have any announcements today about any changes to those flexibilities or limitations, despite the fact that the governor in his press conference yesterday made some announcements about the Hampton Roads region and some of the concerning testing numbers coming out of that region and some mitigation that they are doing in terms of alcohol sales and group gatherings. So again, I repeat, we are not changing any flexibilities, allowances, or limitations at this time, but we do have a lot of other content that we hope will be helpful to you today. We would like to begin with a reminder of where all of you can find these recordings on the DMAS website, along with other resources related to our COVID-19 response. Those are provided on a slide right now. We try to get those slides up as soon as we can, and they are also sent out through our stakeholder list during the same week as the PDF of these slides and the location where they will be uploaded. I'm going to move forward to our next slide. There we go. So we wanted to acknowledge today some important information that has come in over the last few days. On July 23rd, the Secretary of Health and Human Services formally extended the federal public health emergency effective on July 25th. And so that emergency status and all of the waiver and flexibility that is allowed through that the allowance comes through that state of emergency at the federal level. That includes things like the use of non-HIPAA compliant technologies for use of telehealth. That has all been extended through October 22nd, 2020. We have included the link here where that information is posted, but you can also easily Google that information. So that is good news and information that we know that many providers have been waiting to see come out formally. There was early indication that this may be extended, and now we have the formal extension. Next slide. DMAS, in anticipation of this announcement, released a memo extending the timelines for our COVID-19 flexibilities on the 21st. You will note we were ahead of the ball in predicting this extension and released our memo on the 21st, and the formal announcement came on the 23rd. And so we refer you to that memo just for confirmation at the state level that our flexibilities will remain intact through the end of the state of emergency. Next slide. The types of information that are in that memo, which is always available, as you saw on the website, include information about service authorizations, about provider enrollment, about nursing facilities, home health and hospice, durable medical equipment, pharmacy, fair hearings and appeals, and eligibility and enrollment. Next slide. In a related topic, we did want to note for providers today, particularly those who are in Virginia and operating under a temporary provisional license during the state of emergency, that there has been an amendment to Executive Order 57, where one was allowed to have this temporary license in place if one was registered or one was practicing licensed in another state. These temporary licenses are still set to expire as of September 8th. And so there has not been an extension so far of that timeline. I don't have any information today about an extension. I would encourage you to contact with any questions related to that. We just wanted to remind our providers that that flexibility is still just in place till September 8th, and we would encourage a mindfulness around that, and hopefully many of these temporary providers will seek a full Virginia license, and if they are not able, will transition any members that they have been serving over to Virginia licensed practitioners. And we have the information for DHP available on this slide. Next slide. We also wanted to acknowledge here today that SAMHSA and CMS put out guidance on June 29th, 2020 in regards to leveraging existing health and disease management programs to provide mental health and substance use disorder resources during the COVID-19 public health emergency. We wanted to note that DMAS has taken steps that are aligned with all of these recommendations, including expanding coverage for mental health and substance use disorder delivered via telehealth platforms, telephone, and similar mechanism to mitigate the impact of COVID-19. As you all are familiar, we have during this period allowed for almost all behavioral health services to be delivered via telehealth, with the exception of some very few services, including per diem rates. The second recommendation was providing mental health and SUD resources during the COVID-19 state of emergency using online health and disease management programs, connecting enrollees to community resources that provide mental health and SUD support, using mobile apps to provide resources during COVID-19, and providing enrollees and providers with access to other COVID-19 resources. We felt good about these recommendations, and we're glad to see that the steps that we have taken, both as a Commonwealth and as your Medicaid agency, that have been aligned with all of these recommended efforts. Next slide. We also wanted to acknowledge the very hard work led by Margaret Steele at DBHDS, our state partner, and a letter that was published on July 17th, 2020, with health and safety and reopening recommendations. This was a collaborative process across a number of us at agencies and at CSBs. And this resulted in a number of documents that form recommendations. Sorry, distracted by a Q&A coming in. So we have health and safety recommendations from DBHDS for psychosocial rehabilitation providers, for transportation providers, for non-clinic-based providers, as well as clinic-based providers, and then some specific recommendations for therapeutic day treatment providers, which really mirrors the health and safety recommendations coming out of the Department of Education. So those are all available at the provider FAQ link on DBHDS's website. And I see a question already coming in from a provider about whether these recommendations overlap with the more recent recommendations that actually, I believe, came out either the same day or the day after the DOLI VOSH standards. And indeed, they do. And these recommendations that were developed were run through the VDH Mitigation Committee and are aligned with those broader kind of workforce recommendations and guidelines. Next slide. This is hot off the presses. There was an announcement just yesterday coming out from the administration noting that $644.6 million in federal coronavirus relief are going to be distributed to local governments. We have already received a number of questions, but there was a press release. The link is available in the slides where you can see the full memo where many of the answers to your questions may lie. We just learned of this information as you did last night. So we wanted to include it to direct you to the memo, but I don't have a lot of additional information today outside of what is in the some of the highlights of this memo for you to keep in mind is that Virginia received about $3.1 billion as its share of the $150 billion in the Coronavirus Relief Fund. The CARES Act does not require that states distribute these funds to local governments with populations less than 500,000, but the governor recognizes that cities and counties of all sizes have expenses related to the ongoing COVID-19 pandemic and directed these federal dollars to localities. Similar to the first round, the memo notes that the second round of funding will be allotted proportionally based on population size, and consequently the second round of allocations will be equivalent to the amount each locality received in the first round on June 1st. Current federal rules do prohibit state and local governments from using the Coronavirus Relief Fund to replace lost revenues and address significant budget shortfalls. State and local government officials have requested that this restriction be lifted in future stimulus packages or that additional federal funds are provided to address the loss of state and local revenue. You can see the memo for a more comprehensive detail on this new relief package. And just a reminder that the Commonwealth has distributed more than $600 million to K through 12 schools and higher education institutions and $70 million to assist care facilities in providing services for essential personnel. Virginia has also allocated $85 million in CARES Act funding to support child nutrition programs and $219 million for the pandemic EBT program through the Department of Social Services. Next slide. At this time, I'm going to hand the mic over to Jason Lowe so that he can provide you with some feedback on the telehealth survey that was recently conducted with you all's help.
Thank you very much, Dr. Ward. Good morning to everyone. My name is Jason Lowe. I'm the manager for the Support Act Grant, the Division of Behavioral Health, and I am standing in for Laura Reed, our division manager, who's unavailable this morning, to present some more information about the results of the second part of the telehealth survey that was recently done. So a little bit of details on the survey and how it was performed. The survey was opened on June 16th, closed on July 6th. There were 180 total responses to the survey, and of those, 157 were full and complete responses survey that we were able to answer. This gives you an idea of respondent location. It represents pretty strong coverage across the Commonwealth in terms of responses and helps us understand better that we are getting a full view, fuller view of the issues that providers are facing around the state. So in terms of resources, 100% of respondents indicated that they did have internet access, and the vast majority indicated that the quality of that internet connection was average or better, including more than a third both indicating that it was above average and excellent. We asked about equipment or technology that was needed to properly provide telehealth sessions to include simultaneous audio and video capabilities. Again, the vast majority, 88%, indicated that they had all of the resources they needed. There were concerns about lack of access to certain items, including computers, webcams, and smartphones, and then also internet access or Wi-Fi access to allow the connectivity necessary for telehealth. There were a few other responses that included lack of access on the client side in terms of connectivity or devices necessary, as well as having access in the field, HIPAA issues, and internet strength issues. In terms of client telehealth challenges, by approximately a 2-to-1 ratio, respondents indicated that clients are experiencing technology challenges. And then on the right side, you see a little bit more detail about those challenges. The majority of the responses related to the client not having access to devices, not having internet access, or having limited internet access. Some respondents also indicated that clients were not available at times that work for the provider to be able to provide the service. 27 responses to our question about types of challenges the clients are experiencing. The most responses that were indicated were that they need technical assistance in accessing telehealth and a lack of internet access or weak internet strength. Also, lack of equipment was an issue that was raised as well. We asked providers how you're assisting clients to overcome these challenges. The primary means that providers are exploring options for obtaining a compatible device for their clients, as well as exploring options for obtaining internet access through a local provider or free access through local resources, such as open Wi-Fi hotspots at business establishments or at libraries or other civic locations. Other responses including reaching out to managed care organizations for assistance, providing compatible devices or connectivity resources, as well as other responses. Those other responses are detailed here in a little bit more detail. 32 responses to that. The highest indicated responses were providing technical assistance to the clients, as well as going to locations with free Wi-Fi, using the state hotspot map that Virginia Tech maintains, and then also being adaptable and flexible by providing either face-to-face sessions or audio-only sessions. We asked about whether or not you're providing telehealth services, to children and adolescents. By approximately 3-to-1 margin, the answer to that was yes. And we asked you about challenges, if any, you're facing when delivering those services to children and adolescents via telehealth. The majority of respondents indicated that keeping a child or adolescent engaged in the session was the primary challenge, which is totally understandable. Other issues were a lack of interest from the child or adolescent, or scheduling issues with caregivers. I think it is important to point out that almost 1/3 of respondents indicated that they were not experiencing any challenges at all with delivering these telehealth services to children or adolescents. We asked for other responses to that question as well. 22 responses indicated a lack of focus, a lack of engagement, or family or client reporting that there are too many phone calls, as well as issues with adequate privacy and scheduling with the caregiver. We asked a little bit more about types of services as well. The majority of respondents indicated that substance use disorder treatment services are not being provided through telehealth, nor are a majority of providers providing peer recovery support services via telehealth. Also, similar ratios indicating that they are not providing other services for telehealth, including emergency response or crisis intervention. And then a majority of respondents also indicated that they are not experiencing any barriers when trying to collaborate with hospitals and/or emergency rooms during this time of the global pandemic. We also asked about barriers providers are experiencing when trying to collaborate, if there are any. We received 12 responses to this question. The primary responses were that when the provider or client does not have a compatible device, or that they were unable to reach a person to speak to at the hospital or emergency department. Other responses to that question included a lack of knowledge or process about telehealth at the hospital, lack of hospital collaboration, or the hospital or facility not allowing certain telehealth platforms. We also wanted to get input about services not allowed to be delivered via telehealth prior to March 19, 2020, that you would recommend that DMAS continue to allow to be delivered via telehealth. The highest vote getters for this question were behavioral therapy services, case management services, mental health skill building services, preferred OBOT or OTP counseling, and intensive in-home services. Other responses to this question included outpatient, which covers multiple CPT codes, therapeutic day treatment, early intervention services, crisis intervention, and crisis stabilization. We also asked about types of sessions. And the first question there was, what percentage of in-person face-to-face sessions are you providing on a weekly basis? The majority of providers are doing 20% or less on a weekly basis. And in terms of the percentage of simultaneous audio and visual sessions you're providing on a weekly basis, that was pretty well spread out across all of the response options. The highest responses were at either 80 to 100% or 40 to 60% of services that are being done simultaneous audio and video on a weekly basis. In terms of audio-only sessions being provided on a weekly basis, the majority of that was 0 to 20%. And in terms of simultaneous audio and video sessions being provided on a weekly basis, again, high numbers for the 40 to 60% and 80 to 100% response options. We also asked how long it would take for you or your agency to set up your billing system to submit telehealth claims with place of service 02 and modifier GT. The majority of responses indicated that would be up to 14 days, with a smaller amount of providers indicating that it would take either 15 to 30 days, 31 to 60 days, or more. We also asked about telehealth vendor information, asking about whether or not you switched to a new telehealth vendor. On or after March 1st, 2020, 43% indicated that you did, 29% did not, and 28% had already secured a vendor. And finally, we wanted to inquire about HIPAA compliance. 90% of respondents indicated that you are currently utilizing a HIPAA-compliant telehealth platform. We really appreciate everybody taking part in this survey. I can tell you from the support grant perspective that we are using some of this information to inform some of our decision-making. So it's really important data. It's very helpful to the division as a whole. And we really appreciate everybody taking part in doing that. And thank you for your time. I would now like to turn it over to Ashley Harrell to discuss COVID-19 resources available to providers. Ashley, good morning.
Good morning, Jason. Thank you. Good morning, everyone. Next slide. So we want to inform you, if you are not already aware, the Health Resources and Services Administration Provider Relief Fund for Medicaid, CHIP, and dental providers. On June 9th, the U.S. Department of Health and Human Services announced the distribution of approximately $15 billion from the Provider Relief Fund to eligible Medicaid, CHIP, and dental providers that have not received a payment from the Provider Relief Fund general distribution. The payment to each provider will be approximately 2% of reported revenue from their patient care. The final amount each provider receives will be determined after the data is submitted. The deadline to submit applications has been extended to Monday, August 3rd. We encourage providers to apply, even if you are uncertain whether you are eligible. The final amount the provider receives will be determined after the data is submitted, including information about the number of Medicaid patients that the providers served. All providers receiving the Provider Relief Fund payments will be required to comply with the reporting requirements described in the terms and conditions and specified in future directions that will be issued by the Secretary at the federal level. Detailed instructions regarding these reports will be released by August 17th. The website list here covers the eligibility requirements, use of funds, attestation requirements, and upcoming reporting requirements. Next slide. This is a resource that we have provided in previous webinars, but PracticeWise offers innovative tools and services to help clinicians and organizations improve the quality of health care for children and adolescents. Through their consultation, training, and online information resources, they help thousands of professionals who work in children's mental health service systems. PracticeWise now has a series of free webinars that are available for replay on demand. There are currently 6 sessions posted covering topics related to current events impacting our country. Next slide. Our Support Act Section 1003 grant team is facilitating technical assistance and training webinars designed to increase substance use disorder knowledge and to provide support to anyone who serves Medicaid members with substance use disorders. The overall goal of the webinars, as well as other grant activities, is to increase addiction, treatment, and recovery workforce capacity, while also creating a culture of understanding, empathy, and support for individuals with substance use disorder in various workforce settings. Please visit the ARTS website for the sessions led by Paul Brassler, our behavioral health licensed clinician, and Dr. Mishka Turplin, both who specialize in addiction treatment best practices. Next slide. Not only are the upcoming sessions posted at this website, but also the slide decks from any past training. We also post the slide decks from any of the Support Act monthly stakeholder meetings if you're interested. Next slide. We have also posted this free and confidential resource through the University of California, San Francisco, the National Clinician Consultation Center. Their team of clinicians offer clinically supported advice on substance use management for healthcare providers, including peer-to-peer consultation from physicians, clinical pharmacists, and nurses with special expertise in substance use evaluation and management. They also have clinicians who specialize in HIV/AIDS management, perinatal HIV and AIDS, hepatitis C management, and post and pre-exposure prophylaxis. And our own Dr. Turplin also participates. He's one of the physicians that support this warm line. Next slide. Together with the Virginia Department of Health, we are offering free buprenorphine waiver trainings through the American Society of Addiction Medicine. The next training is scheduled for August 26th, and the registration link is posted here. Next slide. We have several resources for you in helping to increase access to life-saving naloxone. Please see the trainings available through the Department of Behavioral Health and Developmental Services Revive program, as well as the Chris Atwood Foundation for the Intramuscular Administration Naloxone. Remember, there is no service authorization nor co-pays for Medicaid members for the preferred drugs, which include the naloxone syringe and vial, as well as the Narcan nasal spray. Next slide. DMAS will soon be posting a language and disability access plan. This will include language access guidance for DMAS providers. DMAS is committed to ensure providers are responsible for providing free language access services to its patient population with competent interpreters and translators. Medicaid members who are limited English proficient and or deaf or hard of hearing are entitled to language access services. This includes the availability of language assistance services as well as throughout the entire Medicaid process, including accessing information about the Medicaid program, completion of an application, obtaining medical services, as well as the appeals process. And Medicaid or the DMAS will have more information on this language and disability access plan coming very soon. Good, now we transition over to frequently asked questions. Question 1 of 2, if an individual discharges prior to the end of the state of emergency, do we have to obtain the client's signature on documents when the state of emergency ends? For individuals in services, providers shall at least note that verbal consent was obtained, and providers shall make reasonable attempts to obtain appropriate signatures, physical signatures, within 45 days after the end of the state of emergency. However, if the individual is discharged from the service prior to the end of the state of emergency, the provider will not be required to obtain physical signatures after the end of the state of emergency. Question 2 of 2. How does the recent changes to 42 CFR Part 2 impact my services with ARTS? The final rule by the Substance Abuse Mental Health Services Administration, or SAMHSA, is to move closer to aligning with the Health Insurance Portability and Accountability Act, or HIPAA, although additional rulemaking is needed for full alignment. We have listed the major themes of the final rule here, as well as posted the link to the Federal Register. Providers should always consult with their legal counsel for advice. And with that, Dr. Ward, any final parting words?
Just want to thank everyone for their continued participation in these events. We do have 249 people here who have been listening in, and we really appreciate your diligence and participation in our efforts to understand the challenges we know you're facing, especially related to telehealth implementation, and in keeping up to date in all of the many moving parts that regulate the practices that you provide in your service. We know that it continues to be a difficult time and that the stress has really built across the system and for the members that we serve. So we just, as always, really want to acknowledge the incredible efforts going on in the behavioral health community to do our best to assure that we reach the people that brought us to this work and serve them the best we can under the circumstances. So thank you for being here today, and thank you for the continued work that you do in the Virginia community. Thanks so much. We'll see you in 2 weeks.